Assalamualaikum and a very good day to Dr. Adani and Dr. Shamin. Today, our group 7A would like to present our internal medicine case clerkship. Our patient name is AMA. He is a 51 years old Malay male. He was admitted to the hospital on 2nd November 2019. He came to the hospital due to a severe chest pain that is crushing in nature and predominantly on the left side of his chest. This pain radiated to his jaw, left arm and his back. The pain is relieved when he took sublingual glyceryl trinitrate. He also experienced shortness of breath at rest and upon exertion. He had on and off chest pain for the last week but not as severe as this one. He is a known case of ischemic heart disease for the last 2 years and was admitted in 1992 for angina. For medication history, he is currently taking metformin tablet 200 mg BD for diabetes mellitus, celecoxib 200 mg PRN, glyceryl trinitrate sublingual PRN for ischemic heart disease, salbutamol inhaler 2 puff PRN for his asthma, and mecobalamin vitamin B12 1 tab TDS for his ankylosing spondylitis.
For list of clinical condition and evidence, patient was diagnosed with unstable angina. Patient chief complaint shows signs and symptoms of unstable angina. And patient also have known case of IHD for 2 years. The signs and symptoms are according to CPG management of unstable angina or non-STEMI 2011. Patient was diagnosed with diabetes mellitus. Patient is in the age range for risk factor of type 2 diabetes mellitus. Patient BMI is 27 kg per meter square, which is overweight, and included in range for risk factors of diabetes mellitus. Diagnosis for bronchial asthma can be proven by patient lifestyle with smoking that increase risk factor for asthma. Patient's BMI was higher than normal, suggests that patient is prone to have poor asthma control due to altered inflammation and immune response. Ankylosing spondylitis were shown to develop 2 or 3 times more likely in men than women.
The first DRP is incomplete regimen for asthma control. The patient has been receiving only Respolin, a reliever inhaler for his asthma condition. According to BTS/SLINE guideline, it recommended low dose of inhaled corticosteroid and SABA as step 1 for asthmatic patient. Besides that, GINA guidelines show ICS therapy is recommended for asthmatic patients with risk factor of exacerbations such as smoking. The intervention is to review patient's asthma condition and consider to add low-dose ICS when necessary, such as there is evidence of poor asthma control. Next DRP is potential ineffective asthma treatment due to smoking. Patient is a heavy smoker and smoking can trigger asthma flare-up, shortness of breath and chest pain, hence increase the need of reliever inhaler. A study showed that high SABA use will increase asthma exacerbation and mortality. The intervention is to educate patient on how smoking exacerbates his asthma condition and advise patient for smoking cessation. Defaulted follow-up and drug therapy for ischemic heart disease is another DRP. The patient has been diagnosed with IHD for 2 years. However, there was a defaulted therapy and follow-up for his IHD which may worsen the patient's conditions. The intervention is to assess patient's baseline clinical condition and start giving suitable treatments for unstable angina, educate patient on the importance of drug therapy and follow-up for IHD. Another DRP found is celecoxib increased risk of serious adverse cardiovascular thrombotic event and increased risk of GI ulcerations. As the patient is a smoker and has a history of PUD, it increases the risk of ulceration complication of NSAIDs. Besides that, clinical trials show that high dose of celecoxib, which more than 200 mg per day, is associated with increased risk of adverse cardiovascular event. To reduce both risks, use the lowest effective dose and for the shortest duration of time. Add combination of gastroprotective regimens such as protein pump inhibitor or histamine 2 antagonist to reduce the risk of ulcer complication. Review patient's frequency of use of NSAIDs. Alternative therapy should be considered if chronic use of celecoxib is required or patient is taking celecoxib more than 200 mg per day.
Our next DRP is no clear justification on the dose increment of metformin, which is 250 mg BD to 500 mg TDS on 3rd of November. This is because there is no supportive evidence for the need of dose increment as patient's blood glucose profile is not available and patient did not show any symptoms of hyperglycemia. Our intervention is to obtain patient's blood glucose level so that we can reassess the need for dosing adjustment. Other than that, it is also noted that patient was on concurrent use of antiplatelet agents. Patient was given tab aspirin 150 mg OD and tab cardipine 100 mg as a maintenance dose from 2nd of November. Our intervention is to give either one of the antiplatelet agents as a maintenance dose. As for this patient, cardipine 100 mg is more suitable as it has glycine to improve GI tolerability. Next, the potential drug-related problem in this patient is adverse effects of aspirin, which can cause chest pain, asthma, and bronchospasm. Since this patient already developed chest pain and have asthma, taking aspirin might worsen this patient's condition. So we have to monitor any occurrence of chest pain or SOB of patients after receiving aspirin. Other than that, there might be potential aspirin and perindopril interaction. Aspirin, if given more than 100 mg OD, may decrease the therapeutic effect of perindopril. Thus, we have to monitor blood pressure and kidney function of patient to consider if any dose adjustment is required. Apart from that, there is also a potential metoprolol and diabetes interaction, as the use of this beta blocker may potentiate the hypoglycemic effect and mask hypoglycemic symptoms. So, we have to monitor blood glucose level and symptoms of hypoglycemia in this patient. Next, there is a potential morphine and bronchial asthma interaction, as morphine use might alter respiratory function and cause respiratory depression. Thus, we have to monitor vital signs and observe the breathing and ventilation of this patient to avoid any respiratory issue from morphine use. There is also metformin and cimetidine interaction, as cimetidine might decrease the excretion of metformin, and hence will cause an enhanced effect of metformin such as hypoglycemia. So, we have to monitor blood glucose and hypoglycemic symptoms of patient. In addition, renal function should also be assessed. Lastly, our DRP is the potential heparin and aspirin interaction. Since both are anticoagulants, concurrent use of these agents at the same time can increase the risk of bleeding. Thus, we have to monitor any signs and symptoms of bleeding and bruising in this patient.
Moving on, the treatment was classified into initial, in-ward, and ongoing treatment. The initial management recommended by CPG is respiratory stabilization through oxygen supplementation to maintain oxygen saturation above 90%. In this case, the patient was given 3 liters of oxygen therapy. The patient was given IV morphine together with IV Maxolon, indicated for pain relief, similar to the recommendation by CPG guideline. CPG recommended dual antiplatelet therapy of aspirin plus ADP receptor antagonist, i.e. clopidogrel. In this case, the patient was given aspirin only. Since the patient had IHD for the past 2 years, he should be considered to be on dual therapy with close monitoring as he had a history of peptic ulcer disease. Next, sublingual GTN is recommended for a patient with ongoing chest pain. If the symptom persists after a maximum of 3 doses, IV GTN should be considered. The patient receives sublingual GTN together with IV isocat. IV isocat may have been started when the patient's condition did not improve despite taking sublingual GTN. The definitive treatment for unstable angina includes antiplatelet therapy. The recommended aspirin maintenance dose is 75 to 150 mg daily, and this patient was given cardipine 100 mg once daily. As for the anticoagulant therapy, the dose recommended by CPG for unfractionated heparin is a maximum of 4,000 units for IV bolus, followed by infusion of maximum 1,000 units per hour, while MIMS recommendation is 5,000 units for the loading dose, followed by 1,000 to 2,000 units per hour infusion. This patient received IV heparin 5,000 units, followed by 1,000 units per hour, which is appropriate according to the MIMS 2020. The patient was also given 50 mg metoprolol twice daily. The beta blocker should be administered early if there is no contraindication, with a recommended dose of 25 mg to 100 mg twice daily. Therefore, The dose of metoprolol should be initiated lower at 25 mg twice daily and titrated up if there is an absent sign of bronchospasm. For ongoing management, long-term ACE inhibitor regimen should be considered to prevent recurrent ischemia. This patient was on perindopril 2 mg and he should continue the medication up to 10 mg daily. Next is beta blocker. Although beta blockers are contraindicated for patients with a history of bronchial asthma, cardioselective beta blockers are not associated with asthma exacerbation. For antiplatelet therapy, the CPG recommends the combination of aspirin and clopidogrel to be continued for 1 month, ideally a year. The patient should continue aspirin 100 mg with the addition of clopidogrel 75 mg daily up to 1 year. Last is lipid-modifying therapy. The statin started during admission need to be continued indefinitely, and this patient should be considered to change to high-intensity statin therapy instead. Other interventions include encouraging the patient to practice a healthy lifestyle such as smoking cessation, regular physical activity, weight reduction, and a healthy diet. Then, the patient should be advised to do regular self-monitoring of blood pressure and blood glucose. The patient should also be educated on the importance of medication adherence. For the monitoring of effectiveness, vital signs such as heart rate and ECG should be monitored. Cardiac biomarkers and platelet counts should be measured. Glucose level and fasting lipid profile should be monitored within 24 hours of hospitalization. Improvement of symptoms should be observed. For safety, prominent side effects and hypersensitivity reaction for the drug regimen should be monitored. In terms of the use of antiplatelets and anticoagulant, the INR level and symptoms of bleeding should be monitored. Thank you.